Good afternoon, welcome, and thank you for coming to our session, which is focusing on Kaduna supply chain transformation. My job will be easy because I'm only here to introduce my team, the Kaduna State team. By name, I'm Pam Steele. I'm the director of PSA Limited, based in Oxford, and partner to the Bill Melinda Gates Foundation, and been working with Kaduna State Ministry of Health. And I'm not the only one there. We have another team, the Plaster Group, Nate there, and E2 Open, supporting with the control tower and Imperial Health Science for the outsourced distribution model. So we're delighted to have you here. We want to take you through our short journey. It's a long journey, but for this time only, it will be brief, focused, so you'll get to ask our questions at the end. I'm delighted to introduce John, who is the Director of Pharmaceutical Services for the State Ministry of Health, Kaduna, and Executive Secretary Ramatu Abdul Kadir, who's the Executive Secretary for the Drug Management Agency. And we have Kasham Patience, who is from the State Primary Health Care Department Agency. So we have other members who are supposed to be here, but due to logistical constraints, they couldn't be with us in time. But we are a people-driven supply chain. And so we started our journey focusing on the people. And this is what they will share with us in a few moments. But then we'll be alternating. John will start, and then Kasham will come in with a short exercise, which we hope will help us learn some ideas from you that can help us along the journey. And then Executive Secretary Ramatu will finish off with telling you the rest of the journey, how we managed to get to where we are today. So thank you very much, and I give over the floor to John. Thank you, John.
You are welcome to the Kaduna Public Health Transformation Supply Chain. We want to take us on the presentation on this outlined. I'll dwell mainly on the introductions. This is just a background of Kaduna State. You can see it's at the center, one of the 36 states of the Federation, Nigeria, as a center of very close to the Federal Capital Territory, that is Abuja there. Those are the coordinates of Kaduna State, a population of 8.1 million with area of 46,000, slightly over 46,000 kilometers square. Also, we have the population density of 130 per kilometer square. We have 23 local government and 255 political wards. That is our governor, Malam Nasir El-Rufai. Actually, when he came on board in 2015, he carried out a diagnosis of the Kaduna health system and tried to assess what is the problem, because his focus is to make Kaduna great again by making sure he focuses on education and health. These are the statistics of Kaduna based on the diagnosis. You can see the public health system is made of the Minister of Health at the helm, and we have headed by the Dr. Paul Manyadogo, who is the commissioner. We also have 3 autonomous agencies: the Primary Health Care Agency, the Drugs and Medical Supply Management Agency that manages the supply chain, and also the Kaduna State Drug, Kaduna State, we call it Kasaka, AIDS Control Agency. Those are the 3 main agencies. And in the ministry, we have 6 departments, functional departments, and one of the departments that are headed, that actually supervise the supply chain is the Department of Pharmaceutical Services, in combination with also the Public Health Department, where the programs are situated. You can see the population density, population distribution of the 23 local government as per the public facilities availability there. You can see those ones in dark, they are slightly above the national average of 5,418. while you see the distributions of the public health or the public sector nurse midwife ratio, you can see the ratio there is just about one nurse to covering about 10,000 populations in the state. It's a great challenge. These are some of the things we found on ground when he came on board, the governor. You can see also there are some basic, I mean, the functionality of those facilities there. See, only 33% of the that function 24/7. Only 33% of the facilities in the state function 24/7. Also, we have access to facilities within that have life-saving commodities. Zero. Just 6% have 6% have the life-saving commodity availability, while 94 are non-available. We also have the basic amenities for a functional PACs. The percentage there, you can see there are only none of them is able to meet. Those were the situation on ground. This we are concerned as much in this meeting is the supply chain. You can see the supply chain in the state were uncoordinated, no collaborations, weak capacities. And you can see there are 3 levels of supply chain at the DMA that take care of the entire state supply chain. We also have the local government medical stores and then the service delivery points. You can see each programs run their own parallel supply chains, and these at the bottom are the facilities covered by the various programs. But mainly this transformation project is, we know most of the other programs are being supported by partners, but the transformation project is focusing mainly on essential medicines, where there was no support for some period, and out of stock and huge expiry were the order of the day. So this is in short to introduce our challenges that we passed through before we started our transformation project. Thank you very much for listening.
Thank you, sir. Well, you are all welcome to Kaduna Transformation Group. Well, before we continue, we are going to have like a brief exercise. We are going to break out into 3 groups, and we are going to give you like a definition of problems, and each of these groups will try to solve our problems. So I'll just quickly read out the definition of the problems, and before we now break out into groups. So the group exercise will take like 15 minutes. So I'll just read it out. Improving the performance of public health service delivery is a top priority for the present government of Kaduna State. This priority has been widely communicated to numerous stakeholders, including international donor organizations and development partners. A transformed health supply chain management system for the public health sector is critical for achieving the priority mandate of an improved public health system. As leaders in your country's public health systems, use the introductory background slides presented to your team, alongside the supporting documents on the various government stakeholders, to develop 5 actionable points you and your teams will adopt in addressing the issues. You will be required to state how your leadership empowers your team in developing the 5 actionable points, particularly situations such as change in government directives and leadership. So the direction will be divided into 3 groups, and we are going to, each of these groups is going to look at one stakeholder. We actually have roles of each stakeholder. The first group will be the Commissioner of Health group. The second group will be the Drugs Management Supply Agency, that's the DMA group. And then the third group will be the Logistic Management Coordinating Unit. So we'll divide ourselves into 3 groups, and based on our roles and responsibilities, we will try to solve the problems of Kaduna State.
So, good afternoon, ladies and gentlemen. All of you are lucky today to be addressed by the Honorable Commissioner of X State. So, if you look at the slide, it shows about 7 bullet points that show some array of issues in that particular state, ranging from programs operating parallel supply chain systems, lack of proper coordination, weak capacity of even the supply chain managers, fragmented logistics data collection system, lack of visibility on commodities, issues about not using data for informed decisions, and of course issues around wastages and loss of especially funds in a resource-constrained state like my state. So after we look at these issues, as the Honorable Commissioner, you know, so the group discussed these issues, and these are some of the key points that we agreed upon. Number 1, we need to prioritize according to the issues that we already have on ground. Some of them are issues that can be solved. They have a short-term solutions. Others, of course, will require long-term solutions. So for us to be able to address these issues as a commissioner, don't worry. So as for that, all I need to do is, as the boss, is set up some technical working groups, of course, through the MDAs. Looking at the issues, I would like at least 2 committees to be set up, the Logistics Technical Working Group, and of course the M&E Working Group that will be looking at the quality of the data that is being generated. And of course, which I will task them to address these issues as quickly as possible. At the same time, because of the lack of capacity of some of the supply chain managers, of course, I will bring this issue into the Executive Council meeting so that the supply chain managers can be given trainings that locally or even internationally as the need may be. Also, if there are some issues that will require policy issues, it is my responsibility as a commissioner also to table that at the higher level so that those issues can be actually addressed. So, most importantly is I will request for feedbacks from these committees, and I will hold people accountable and responsible if I see this, at least there should be some significant reduction, if not eradication of all of these issues. I'm not a commissioner, so that is why.
Thank you very much, Commissioner of Health. Okay, so let's quickly hear from Group 2 before we give a general. Okay, this Commissioner of Health, Group 2 is the Drug Management Agency. So he's the Executive Secretary of the Drug Management Agency.
Yes, and I have very important functions to perform. I'm responsible for procurement, quality assurance, storage of commodities, inventory management, order management, distribution, and waste management. So, distinguished ladies and gentlemen, I think you are in the cabinet. You are the cabinet of Kaduna State. I think we have a multiple marriage of problems, I think, quite a lot. And the 5 actionable points that we want the cabinet to consider is this: to give us these powers to define the roles and responsibilities of each of these partners, who owns what, who is funding what. So we want the governor to give us that power so that we quickly just get to action and set everybody up to do what he's supposed to do. And then we also want to map the potential integration pathways that we would like to have, and that we are not just going to do it anyhow. We're going to measure the maturity of each of these supply chains to see where the constraints are and which one can take on this and which one will not take on that. And then we would like Governor to consider that we integrate the data coming from the supply chain so that we can start to have visibility across all the supply chains. And it makes it easy to identify common things among the supply chains and then integrate. And then, okay, I think this one was part of this. They identify which supply chains are working well and which ones need to improve will be part of the things that we'd like to do, and then capacity building of the personnel, especially at the facilities. That's right. So this is the work of our group, and we brought in actually experts from outside to help us decide this. Across the continent, we have somebody from India. Across the other continent, we have somebody from Europe, and we had a government officer that was our commissioner that was in the middle of finding these solutions, was just moved to another place. Thank you.
Thank you very much, Group 1 and 2. Thank you very much for all the great ideas. Okay, we're going to have the next presentation. We are going to have Group 3 present their findings or their solutions.
The Francophone group. It was difficult to understand. It was the first step. We have to understand the exercise. Okay. And so we haven't finalized the exercise, but we have 3 measures for address this lack. The first is address to each program operates their own health commodity supply chain system. It was the first problem, and we say that we have to integrate and harmonize. Okay. Les outils de collecte.
Now the tools for collecting.
The tool for collecting. We have to harmonize the tool for collecting. The second action is to have one system of collect. There is a lot of system of collect. Each program have a system. We have to harmonize and coordinate for one system of collect. And we have to reinforce the personnel capacity. We have to reinforce the personnel capacity. Okay, I think it was 3 action, the Francophone group. Thank you.
Thank you, Francophone group. You actually did well. You understood the question, really. That group was the Logistic Management Coordinating Unit. They are responsible for data management and coordination. They also have the capacity needed to complete distribution, waste management, and performance management. Actually, based on this chaotic supply chain, all of you actually brought out many good solutions to our problems. So after this whole thing, after this presentation, we are going to tell you what we did. There was something that happened. We had to move some people from one group to another. So how did you feel being moved from being commissioner to DME?
Well, first of all, it was a pleasure to participate in that team, but we picked up quite quickly in this team on exactly the same points. So it wasn't about me, it was about the teams and the synergies between the teams.
Okay. So did you blend in nicely? Did they welcome you?
Absolutely, yes.
All right, that's good. Okay, then the second, well?
I talked less.
Oh, really?
Yes, that was the reason I was talking.
Okay, let's have your own views.
I was very sad to leave my group and not know what the outcome would be. And it was hard to get into the new group, actually, because they were in the middle of a good discussion already, so it's hard to break in.
So we actually noticed that confusion. Okay.
Well, our group was rather annoyed that you took her away because she was our recorder, and So we had to scramble to find Post-it notes and the markers, and so.
We also noticed that your recorder went with your whole records. We had to follow her to collect it. No handing over, no communication. She just left, you know. So, well, we actually wanted you to understand, like, confusion that we actually face in Kaduna State. Sometimes we have serious policy changes, you know, key stakeholders being moved abruptly. You just wake up overnight and find out that your commissioner is no more without handing over, without you being notified. You just wake up. Like within 6 months, I think we've had like 2 commissioners and we've had 2 permanent secretaries. So you can imagine 3 permanent secretaries actually. So you can imagine the confusion. A commissioner is in the middle of something, he's removed abruptly. Most times they just give him 2 days notice or a day notice. So he trying to come to the realization that he's been moved, you know. So he just leaves abruptly without proper handing over. So you can see the serious chaotic problems you're actually having in the state. So really we did this role play so that you also understand some of the challenges we are actually facing. And you know, even at facility level it happens. So I will just hand over to Pam for her to continue.
Well done, team. I mean, isn't it familiar, especially for those working in public service, that these changes happen? And that is why in Kaduna, we decided to focus on people. Because change happens, but when we bring in these new approaches, we want to transform the supply chain, but without thinking of how the changes that are going to happen are going to affect people along the way, throughout the whole, all the levels. So for me, the message has been strong that technologies make things possible. Technologies make things possible. But people make it happen. It's the people who will make it happen. And then we will also see that people only support what they help create. And that is why in Kaduna, we have been working with everyone from cleaners to pharmacies and, you know, all levels, facility level to high level. We've had session with senior directors, actually, senior leaders, including PS in the room, just discussing about how we should bring this change for them to be able to buy in at their level, but also at the lower level. So this is where the people aspect is going to come in, which will be presented by Executive Secretary Ramatu Abdul Kadir.
So, thank you very much for that very beautiful exercise, and you all did wonderfully. You are hired. Yeah, you are hired to solve Kaduna's problems because you have the answers. So, no. So, how did it all start? We used 8 guiding principles, and these principles, we used it at every step, every stage of our transformation. The Kaduna State government asked. This was not the partners coming in to say, oh, I have this to sell. We asked for help and in trying to understand the facts of our essential medicine supply chain. Because you'll notice that for most countries, the vaccine supply chain is well developed. It's also well developed for us. They are far ahead. But for the essential medicines, we're just starting from scratch. So we had health system diagnostic assessment was done, and this was also reviewed. And during that review, we identified the health commodity supply chain management as the one priority intervention area. And then we approached the BMGF to try and help us find solution to all this myriad of problems that we had and you had also experienced with us. So the Gates Foundation answered our call. And then we came in and had pilot design. And then I had somebody talking about roles and responsibilities because in the past we didn't know who was doing what. You know, roles were not clear. So we had that with the pilot team. And also we undertook, that took 1 month for the pilot design. Then we had the preparation for pilot, which was 3 months. And this involved warehouse preparation, selecting of facilities, cloud-based visibility, and performance management framework. And this is the timeline for the pilot. The BMGF came in with technical assistance from Pamela Still Associate. Hi, Pam. Thank you. So, and E2 Open, and of course we've heard about Imperial Health Sciences. They handle our third-party logistics. Yeah. So this is a cascade of our transformation journey. We are currently at the test and select level, and our transformation has 3 stages, and that's the pre-implementation stage. We have the implementation stage, which is where we are now, and then there's the post-implementation stage. So, Pam has talked about people. We realized the importance of people in our van, so we worked a lot on people. And this is a picture of mapping key stakeholders. We had to decide who were the key stakeholders, and that cut across a lot of agencies: the primary healthcare, the LMCU, the ministry, the budget and planning, the finance, everybody needs to be involved. And of course, we listened and tried to understand what the problems were across all levels. And then the change effort. Transformation involves a lot of change, and you have to manage that change. So we have the change management team was constituted, and you can see a nice picture of the change team. And we deployed the RACI concept. Who is responsible? Who is accountable? Who should be consulted? And who needs to be informed? This goes all the way from the executive governor down to the cleaner or the gate man. So, at that stage, we also determined our baseline cost. We realized that nobody knew the cost of our supply chain. So we needed to know that, and we deployed a tool to find out our baseline cost. You can have a chat with us later so that you can get the information about that. And we didn't just stop there. We tried to disseminate this information and findings that were gotten. This is the Director of Health Commodities at the DMA disseminating in Tanzania. So we had shared, and we're still sharing our findings. So for the implementation stage, we had, these are the target areas, the warehousing. We looked at order management, distribution, data visibility and analytics, performance management framework, financial management, and communication strategy. And what were the expected benefits? Real-time health facility data visibility, ease of tax burden to health facility personnel, because in the past, what we had was facility managers coming to the drug management agency, and you appreciate it from the landmass. We have facilities that are 3 hours or 4 hours away from the central capital. So, and that person or the nurse has to leave all her patients to come and get the drugs. We also expect to have effective utilization of available human resources, establish KPIs, availability of quality medicines and commodities for healthcare delivery, and health commodity security. So the purpose of the pilot were to support the state as it tests, learns, and repeats its way. We don't have a template. We are working, we are learning, because our system is unique, our people are unique. We don't have anywhere to go and get that. So we test, we learn. If it works, we repeat. If it doesn't, we test again. So, to also identify any operational challenges, to obtain a preview of the supply chain performance before committing to a full-scale implementation, to equip the Kaduna State change management team with soft and hard skills. So, for the pilot, we had 2 committees. Oh, the commissioner wanted a technical working group, so you have it. We have the steering committee. The commissioner always gets what he wants. So we have the steering committee and the operations team. And you can see them trying to figure out the problems. The implementation stage involved preparation of the warehouse. And you can see the picture of a large stump obstructing a warehouse. So, and this is the as-is picture before the implementation. We selected 28 facilities, 23, 1 from each local government, and 5 secondary healthcare facilities. And these are representatives from all these facilities having a training, a 3-day training before the rollout. process mapping. We had our process mapping. This is the LMCU. Oh, you can see Nate. Hi, Nate. So we all did this, the process mapping before the pilot design. Critical successes recorded. This is the warehouse after the implementation. You can see that stump is missing. It used to be here. So now it's gone. And then this is very important. This is our deputy governor representing the governor at the pilot launch. This is the commissioner. This is the chairman, House Committee on Health. And this is just to demonstrate to you that we have a lot of political will. The governor is passionate about health, and we have a lot of support from him. The LMCU engaged 28 facilities, and we collect consumption data bi-weekly. And it's important for you to know that we are also building our van from scratch. It's going to be customized for Kaduna State. We don't have anything we're working with. So the last mile distribution, like we mentioned, Imperial Health Sciences is handling our third-party logistic. This is a pick and pack process at the Drug Management Agency. And now what happens is that facilities send in their requisition. They don't have to travel all that miles to the capital. And then we process it, they pay, we pick, pack, stage, and ship out to them. This is last mile distribution, loading of trucks for delivery to health facilities. So challenges, we had a lot of them. Poor handover knowledge, like the commissioner that moved away with all the information and left the group confused. So, and then also, we had issues with weekend deliveries because if you remember, our first presenter was talking about facilities not operating 24-hour service. So that was a problem. Accessibility was also an issue. We had curfews in some local government because of issues that have been happening, and that was also difficult for us to handle. Inconsistency in price list. The sustainable drug supply system we are managing is supposed to have markup, but those markups were unavailable, so facilities don't have funds to work with. And consumption data tools were difficult to use. There was also unwillingness of facilities to document daily consumption. Insufficient amount of products at the Drug Management Agency because we didn't have their consumption record, so we couldn't plan properly. And then, of course, we needed more time, better allocation of time for the visits to the facilities. We had problems with banking and payments. Timelines were not adhered to. And then for some local government areas, the banks were difficult. In fact, some didn't have banks, so they have to move to another, maybe 3-hour local government just to pay for their commodities. And then incomprehensible handwriting, payments made with abbreviations, it's difficult to match who is paying for what. And then we had policy issue of treasury single account. So a lot of funds of facilities was trapped. And then facilities didn't have funds to come and buy drugs from us. And of course, it's cash and carry. Also, facilities didn't have SOPs. Data collection processes were not there, making payments and last mile delivery and also shipping at the facilities. What have we learned from these processes? The change in leadership style from bureaucratic to transformational, because we learned that we just had to do away with some things. If you said you have to go through all the processes, you will not get anything done. Potential significant increase in time spent providing services to patients. Because we're able to free the healthcare personnel from the troubles of the supply chain, they had more time for their patients. And also after the training, and we're able to sell the ideas to the facilities, they were more enthusiastic to practice documenting daily. Pilot facilities have clear visibility of higher level supply chain. They know who is doing what, who is supposed to be sending requisition, who is picking, who is shipping, who should be receiving. The roles were clearly mapped out. And then we also realized that policy review was required. We have to change our policy to reflect our transformation. The quality of consumption record cannot inform resupply and decisions. So these are things we're all working on. There is a work in progress. Sustainable data collection process is also needed. We have to review our payment systems completely, and overhaul is needed. And then we realized that we needed a standard template for documenting lessons learned. The next steps we were looking forward to are for the 28 facilities, because the pilot is running for 3 months. We're at mid-pilot now, 3 months. So we still have 3 months to go. So we are deliberated that the 28 facilities will have to be excluded from the sustainable drug supply system so that we can actually monitor our transformation properly. We have to review our operational guidelines. We have to develop SOP for all pilot processes and review them periodically. We have to train the health facilities, LMCU, DMA, or keep retraining because we have so many trainings that have been going on. So, and then of course, we have to monitor pilot processes for adherence to SOPs and document all variation and non-compliance. In conclusion, we use 8 guiding principles, which I told you about. There's a state level ownership at every step, everybody is involved. So that when BMGF leave, well, we're still there to carry on working. Systemic thinking was carried out all along. We visualize our success. We know what success looks and feels like. Fact-based intervention. We talked of the diagnosis, we talked of baseline cost. So we don't just do things, we have to have facts before we go into them. Intervention and collaboration. There's stakeholder collaboration across the entire state. Engagement of capable technical assistance, BMGF, PSA, E2 Open. Use of lessons. At every stage, we come back and sit down, we look at lessons learned, we review them, and we move forward. And of course, the last but not the least is commitment and sustainability. Thank you.
Right, thank you very much. We allow some questions here.
So I have a question, and in the 2 groups I worked in, one of the first things that came up was a clear definition of roles and responsibilities up front. When you have changes of leadership like that, didn't you find that the clear definition of roles and responsibilities allowed people to carry on working and not stop everything because we now got a new leader?
Good question.
That is where we are getting it right. We've not really gone far, but that question you said applied to me. I came in when the transformation was like over a year old, and I just sat down. I wasn't confused. I tried to listen and learn, and that's where we engage all our 8 guiding principles. And then I was able to fit in, and I'm barely 6 months, and we've done that.
She's the lead change person in her area.
Okay, so first of all, congratulations. I've been trying to get into the Kaduna State project for quite some time, but I don't know. I wasn't permitted into coming in, but I have all the secrets now. So, secondly, because I was just talking to Olubimi. Yes, so because I had been working with Lagos State and their essential medicines program, and looking at what you've done, you've actually gone kind of far ahead. But there was one problem they kept identifying as a challenge, and I would want to know how you solve that. That one is about how the facilities, how they send their report to be able to, like their requests for reorder. And then 2 is, because they've said that's a major challenge. They bring it physically, unlike you said, they don't have to have that issue of the commodities being sent to them. In Lagos State, they bring it physically, they go back waiting for the supplies to come back. But then I think one challenge they said was that at times they have 5 facilities, 6 facilities come within a period, and then they only have few staff at the warehouse trying to coordinate this. At times they stay till late in the night trying to make sure people get their orders. And because also the same challenges you had, which was they didn't use the consumption data to do the initial forecast, they have situations where facilities come back within a week or within 2 weeks requesting for supplies. How have you been able to manage that?
Good question.
Yeah, I think our problems are very similar. We had the same issues too, but that is the essence of the transformational. We just had to skip a lot of things that were required. You see, in the past, you must bring your requisitions, get a pick list, pay, and then bring a teller. You know, it's so cumbersome before we can even begin to think of pick and pack and then shipping. But in our own case, what we did was that because we had the LMCU going to the facilities to get data, so what we did is that when they are coming back, they come back with the requisitions. The facilities don't need to come. And then we get their pick list. And then we also inform, the LMCU informs them, okay, you give us a requisition, your amount is 200,000 naira, you can go and pay. And then they'll go and pay, we'll get an alert. And that's why we're having banking issues. When somebody goes to pay, instead of him to write PHC, Kayarda, he'll write primary health care, and then we'll just see primary health care K. And then we'll be wondering, because we have so many other Ks, we'll not know who it is. We have to make calls to all the Ks and know which K and compare with the pick list. So that is what we use. The LMCU gets that requisition. But we're also thinking of so many other options because it doesn't make sense for facilities to come and bring requisition and then you ship products to them. So we are looking at technology, what will make it easier, something simple, user-friendly. We're thinking of phone calls, you know, before we actually deploy our van. Yeah. Oh, okay.
One question.
Thank you for the presentation. It's really transformational. I just need a clarification. I heard you mention about separating your 28 pilot facilities with your SDSS. Are we running two parallel programs, or what's the thinking through this?
That is because our SDSS is restrictive. We already have SDSS guidelines. And if we go by the guidelines, you have to pay. There are so many processes that have to be paid. And that's why we're talking about transformational leadership. Like we had issues for the first order when people requested for drugs. And you are wondering, okay, so where is the teller? Well, he paid in 3 hours away. You don't have a teller because you need a teller to issue receipt and then you pick. So what we did was that, okay, no tellers. He has the teller, pick and pack, stage and ship. When the third-party logistic delivers, gets proof of delivery, come back with our teller. So what we are saying is just to keep them out of that restriction, or else we will not be able to transform.
But you could also, I would also want to recommend, you could also review the SDSS guidelines.
We will. We will.
I was part of the team that developed the SDSS guidelines under the DFID program.
Yes.
So it's a working document that, as Kaduna State,
Yeah.
you can sit down and review the processes and say, this is not working, this is how we can make it more efficient. And then you can just...
Correct.
Those documents are due for review.
They are due for review. They are due for review. But like as you have seen, we employ systemic thinking. We don't want to rush into things. We want to finish our pilot, see all our problems, learn our lessons, and then review our operational guidelines in line with our transformation. Thank you.